All right. Good morning, good afternoon, good evening, and thank you all for joining us for what I hope will be a very interactive conversation. I want to thank everyone who is joining us from here at UT, but also folks joining us from around the country and also our partners in Cameroon, in Zambia, and in Israel. So I am Denis Foretia. Today I will serve as the moderator for this conversation. A brief introduction: I am a general and acute care surgeon and currently director of our Center for Multicultural and Global Health here at UTHSC, as well as the associate director for our Global Surgery Institute. Today, we want to really have a look at healthcare in rural America, in rural Tennessee. And we know that rural America faces a very unique set of challenges, one of which is the peculiar nature of access to quality health services. Our goal today is that with this conversation here, we will really have a better understanding of the care that's delivered in our rural communities, the challenges that the communities face, and really some of the initiatives that have been put in place to help in achieving equitable access to surgical and health care. So today I'm very, very honored to have two wonderful experts, Dr. Sarah Rhoads and Tom Kincer, who are joining us today for this conversation. Dr. Sarah Rhoads is a professor and the chair of the Department of Community and Population Health here at UTHSC. Prior to joining UTHSC faculty, she was the director of the South Central Telehealth Resource Center, the education director for the Center for Distance Health, as well as an associate professor in the Department of Obstetrics and Gynecology at the College of Medicine, all at the University of Arkansas for Medical Sciences. She has been the primary investigator on multiple grants related to telehealth. Several of her research and project grants have focused on the Mississippi River Delta region. We are very, very honored to have you, Dr. Rhoads. Thank you for coming.
Thank you. I'm excited to be here.
Also joining us is Dr. Tom Kincer, who is professor in the Department of Family Medicine and the Associate Dean for Rural and Community Programs at East Tennessee State University. He was born and raised in Eastern Kentucky, and growing up in this region gave him really a first-hand knowledge of the education and health needs in the Appalachian region. As the Associate Dean for Rural and Community Programs, one of his main roles is to recruit and train students in rural and underserved community of the region. So Dr. Kincer and Dr. Rhoads, really wonderful. Thank you very much for honoring our invitation today. Let me start with you, Dr. Rhoads. Just to kick off the conversation in a few minutes or so, could you help us with a brief overview of rural Tennessee, the different regions that make up rural Tennessee, how healthcare is organized, and how similar or how different it may be compared to our urban centers?
Well, for those of you not familiar with Tennessee, it's a long state and it's comprised of 3 regions, with West Tennessee, where I live in the Memphis area, is in the Mississippi River Delta region, and it's comprised of rural areas and has a lot of agricultural acreage and areas. It has the highest poverty rate of the 3 regions and the lowest income rates. Whereas Middle Tennessee, where Nashville's located, has rolling hills. It's the largest of the 3 regions. It has the highest per capita income, more educated and insured residents, and better health outcomes. East Tennessee, where Dr. Kincer lives, and he can speak really well on this, but it's mountainous and it has the Southern Appalachia Mountains and the Smoky Mountains. It also has challenges related to poverty rates and worsening rates of heart disease, stroke, and diabetes. And really, where you live depends on how long you will live in the state of Tennessee and the region, with the lowest life expectancy being 64 years of age in Washington County, which is in East Tennessee, near where Dr. Kincer lives, and the highest rate being 88 years of age in urban Rutherford County, where Nashville's located. A few other points to know about Tennessee: 69 of the 95 counties are designated as fully rural by the Health Resources and Services Organization. They have higher rates of older adults living in rural areas, but oftentimes rural areas don't have access to services such as housing, social services, transportation, nutrition services, internet access that helps people age in place. And then a few other points, drivers of health are health behavior, physical environment, social and economic environment, and clinical care. And all of these are interwoven. So decreased access to healthcare, job opportunities, social services impact health outcomes. So if you look at any map of Tennessee with any health factor, you can see that East and West Tennessee regions fare far worse than Middle Tennessee. For example, for one of my projects, I looked at food deserts. And so East Tennessee has a lot of food deserts and West Tennessee has a lot of food deserts. So even social services that can help that. If you don't have transportation to get to the services, you may not even have access to those food. How healthcare varies in the two regions. 20 counties in Tennessee don't have a hospital, and rural hospitals have been struggling to stay open. Over the past 10 years, 13 hospitals have closed their doors. And one area of particular interest of me is obstetrical care services. 71% of Tennessee counties don't have a hospital or birth center. So our residents have to drive to deliver a baby. And we know that mothers have better outcomes the closer they live to a delivering hospital, and maternal death rates continue to rise. I could talk all day about rural health and rural health outcomes, but I'll pause and let Dr. Kincer talk.
Yeah, no, thank you. That's very sobering already, of the fact that really Middle Tennessee has comparatively better healthcare, so to speak. Life expectancy is comparatively better than, West Tennessee and East Tennessee. And also really the sobering nature of the fact that, 20 counties or so do not have a hospital, in the state. And 13 hospitals have had to close in recent years across the state. That's huge. In just the sheer numbers of the fact that 69 out of 95 counties in Tennessee are rural counties. So it's a major component, close to more than 70% of the counties or so are rural counties. Thank you very much, Dr. Rhoads, for that wonderful overview. Dr. Kincer, let me get your general assessment of the current state of healthcare in our rural communities, our rural counties or so. Where do we currently stand?
Yeah, thank you for the opportunity. A disclaimer is that there's going to be a lot of things that Dr. Rhoads and I talk about today. I don't think either one of us are going to profess to be experts in every little detail that we'll touch on, because healthcare is so broad and it takes so many different individuals. But we're going to provide a good overview and people can ask questions, and we will try to answer to the best of our abilities. As much as we do this, we do understand that it takes a lot of people to generate healthcare, no matter which country, which state you're in. But as far as Tennessee, overall, there's a higher incidence of chronic disease in rural America, or just rural anywhere in the world. Especially noted in Tennessee is a higher burden of diseases that are secondary to diet and tobacco, such as lung cancer, heart disease, obesity, diabetes, hypertension, and different kinds of cancer. We also see in Tennessee an increased incidence of diseases of despair. Diseases of despair are drug overdose, suicide, and alcohol liver disease. We commonly think of these in people who are socially stressed or socially desperate, looking for ways to mitigate their stress, their mental illness, and they reach to drugs and alcohol, and they have higher rates of depression. And so we call those diseases of despair. Other issues, as Dr. Rhoads alluded to, include a higher infant mortality rate in Tennessee compared to the United States in general, which is 5.8% in the US and about 7.2% for Tennessee. She may go into that in a little more detail since that's her expertise. We have more mental illness, and We also have a higher teen birth rate in Tennessee than national average. While these figures are staggering, these are not new. In the early 1900s, public health measures shifted the major cause of mortality from infectious disease to what we call degenerative diseases. Degenerative diseases are a result of lifestyle, diet, abuses, environment, and an increasing life expectancy. The longer you live, the more degenerative diseases you're going to get, the higher likelihood that you are to get heart disease and cancers and so forth, just because you live longer. Degenerative disease prevention requires access to education, healthcare providers, and employment, which drives income. And income is the most important social driver of health. Rural communities have always struggled with these measures, but the disparities between urban and rural continue to widen as we go through our decades. Okay. This occurs for two reasons: decreasing access to health care in our rural communities, and we'll get into hospital closures and all that a little bit later in the talk, and also because there's an improved access to healthcare in urban areas. Much of the decrease to access to care in rural Tennessee over the past decade has been driven by the closure of 13 rural hospitals. I think we're second only to Texas. I think Texas had 21 and Tennessee's had 13. When a hospital closes in a community, it has an enormous downhill effect on the community by decreasing employment opportunities, therefore driving out physicians. If you're an OB physician in a rural community and you deliver at that hospital and the hospital closes, you no longer have the ability to practice OB in that community and you're going to leave. And that decreases opportunities for health, and it decreases the employment of people in the community, and also a tax, which we'll talk about later. You decrease healthcare facilities, and all of this just decreases the overall well-being of the community. And we'll get into why hospitals closed later on in our discussions. But this is a good overview for you.
Wow. I mean, I think, yeah, that is, you know, one thing that's very interesting from listening to you, Dr. Kincer, is like these diseases of despair really is a big issue in our rural communities, the diseases of despair, and the fact that the whole degree of work that needs to be done in managing or treating degenerative diseases, really access to education and income generation activities is a big one. And also notable is what you say, that the disparity between rural and urban communities, you know, continues to widen. And there is some evidence that, as you mentioned, that there is improved care, access to care in the urban area. So those are very interesting and facts. So thank you very much, Tom, for that. Now, some of the areas that you've raised, I mean, you talked about the critical access. Dr. Rhoads has mentioned that as well. But Dr. Rhoads, there is a lot of conversation, as you're saying, regarding these rural health disparities. You know, Dr. Kincer has already mentioned some of them as well. From your own vantage point, how do you see health disparities in rural Tennessee?
Well, I see that it really, not only in Tennessee, but like the Mississippi River Delta region, so eastern Arkansas, western Mississippi, a lot of these counties have worse outcomes than counties compared to other counties in the state. So the counties in the Mississippi River Delta region fare worse than other counties in their state. And I think a lot of it has to do with access to care and access to services. Many rural communities are resilient, but also from living in a small town, and I know Dr. Kincer has too, you can't go to Walmart without people knowing that you're there. So if you're trying to access mental health services or HIV care or other types of services, you may want to drive another county. So that's that, or to another county or to the other health center in another area. So many people that live in rural communities, and I'm so glad Dr. Kincer said that all rural communities are different, and so one rural community is not like another, but they do tend to be very proud, and they do want to have privacy and things. So I think that compounds health disparities. Many rural areas are designated as medically underserved communities, and there are healthcare provider shortage areas. As Dr. Kincer said, many rural hospitals, but also rural clinics struggle to stay open. And then if people may go to a rural community for a few years, so their student loans will be paid off, but then move back to the urban areas. I know nurses that personally drive from one rural community to an urban community to work, just because of, more pay and more services and support system for the nurses. So many rural hospitals have a hard time filling not only nurse positions, but physician positions and other allied health professionals in hospitals.
Yeah, so wow, that's one of the things you just mentioned, which I had not really thought about, that the issue of privacy. Like you said, you can't really go to a Walmart, in some of our rural communities without being, without people knowing that you're there. Everybody knows that you're there, so it becomes very difficult to, as you said, access HIV care or some of the other things where it's there are all stigmatization attached to to the types of care. That's a very interesting problem that I don't think that without living in a rural community we tend to think about. So I mean, I really appreciate that. Now, one of the things that Dr. Kincer, you mentioned earlier was really, and Dr. Rhoads also mentioned, is the closure of the different hospitals or so, health facilities, 13 health facilities or hospitals that have been closed in Tennessee. Only, as you mentioned, only Texas, where you've had more hospitals have been closed in Texas compared to anywhere else. And, we are unfortunately a close second, or very competing for that top spot. But, Dr. Kincer, can you, talk a little bit about, the drivers in this, this trend for closures? What is pushing the hospitals to close? Is it a lack of personnel? I know Dr. Rhoads mentioned difficulty filling certain positions, physicians, nurses, allied health providers, or so. But from a statewide lens, what from your point of view is driving this?
Yeah, thank you again for the question. It's an extremely important question. Sadly, I don't think that we have all of the answers. We know that it's very multifactorial, but ultimately it's going to be that the expenses of running the hospital exceeds the revenue brought in. So let's take a look at that. So just a couple of months ago, there was a news report in Nashville that cited the high number of uninsured or underinsured patients in rural communities causing an economic collapse of rural hospitals. I think that it's a lot more complex than that, but it does play a role. But as I said, it's ultimately that the hospitals don't have the revenue coming in to keep the doors open. And this is not linked directly to a lack of providers, whether that providers are physicians, nurses, or other hospital ancillary personnel, but albeit it is an issue to some degree. In fact, the opposite is probably true, is when the hospitals close, you see a mass exodus of providers because there's no hospitals to support them. So they leave, and as Dr. Rhoads said, you've got nurses now that live in rural communities that drive an hour or more to try to get to a hospital to be able to work. Expenses for hospitals are going up. Most of us now use electronic medical records, but I lived and practiced in a time long before electronic medical records came along. Electronic medical records are extremely expensive, costing millions of dollars to put into a hospital. And small community hospitals, they really don't have millions of dollars lying around to just put into electronic medical records. And the expanse of the Centers for Medicare and Medicaid has caused increased needs for reporting, the mandatory use of EMR. So if you're not using EMR, you're not going to get paid by CMS. And Medicare and Medicaid are huge drivers of income for rural hospitals. Supplies go up, the cost of a new X-ray machine goes up, the need to pay your personnel to be there. Dr. Rhoads said, the nurse can go to an urban community and make more money than she could in a rural community, or he. So you get an exodus based on income. The cost of building management goes up, building supplies, the cost of electricity, water, all of that goes up. And hospitals are not immune to that. And then you got a decrease in the payment model. CMS, in order to try to, because healthcare cost all over is increasing, and CMS only has a certain amount of money, they can't print new money. So they have to look at creative ways to try to take the money that they have and distribute what they might call fairly. So they start bundling payments. And by bundling payments, that means we're not going to pay you separately for a CAT scan and an EKG and all of this. If the patient comes in with a diagnosis, you get X amount of money no matter what you do to them. And that's bundling of payments. And small hospitals, they don't have the patient volume that they can survive on bundling. Competitive payment models. And what I mean by competitive is we're going to take all of the hospitals and we're going to put measures in place. And the hospitals that outperform the other hospitals are going to get more of the money, and the hospitals that, quote, underperform are going to get less of the money. Well, rural hospitals, they don't have the personnel that they can hire to be as competitive. They may not have the most up-to-date EMR system that you enter all of this data to really perform in a competitive model. So their payments go down, whereas the urban hospital payments go up. So that's a way of penalizing, if you will, rural hospitals. And speaking of penalties, you get penalties for things like 30-day readmission rates. Mm-hmm. Well, if you're in a rural community and you don't have long-term care facilities, you don't have home health, you don't have short-term rehab stays, and you discharge a patient, you're much more likely to get a 30-day readmission than you are in an urban area. And then you get penalized for that. And then you have a higher rate of the uninsured or the underinsured, all of these decreasing payments to hospitals. So expenses going up, payments going down, rural hospitals caught in the middle, and they have no option but to close. And so, as I stated earlier, the hospitals closing drives out other healthcare providers. And in rural communities, healthcare is one of the top two economic drivers, with the other being education. And so when a healthcare facility closes down, it's just a downhill effect from there. It decreases family income, it decreases tax-based revenue for the community, it decreases employment opportunities, and then you get a youth drain or a brain drain from the community. Youth have no place to work. Community has no place to work. So people that have education, they leave. They've got to go somewhere else to live. And so what you end up with ultimately is an aged, unhealthy, poor population living in these rural communities. And it slowly happens over time. And now these communities would love to attract new business. But you can't attract new business when you don't have health care, your education system's poor, you don't have a workforce left in the community to attract somebody that wants to come in and build a factory or a plant. They look at all of this and they go, oh, we can't survive here. So they go to a more urban or suburban area. And so, as I said, it's a downhill spiral. You close one rural hospital, you've basically killed that community.
Yeah, I think that's a really very sobering assessment there. The economic, expenses, hospitals not being able to meet up with the expenses or so, but really, you're having all the national, the federal mandates with the Center for with CMS, CMS mandates, mandatory electronic medical record use, very expensive for that, and all the payment modules, and as you said, not having long-term care facilities in these communities really makes it in such a way that all the facilities get to be significantly penalized for any kind of readmissions or things like that. I think the aspect of education and healthcare being the main the two main economic drivers. So I think like you've really hit that, and thank you very much for that. I wanted to, Dr. Rhoads, I wanted to talk a little bit regarding, shortages of personnel. I know nursing shortage is a national phenomenon, something that, we currently see at our hospitals of significant nursing shortages. So what is your experience in this area? Could you talk a little bit about, the access to nursing services in rural Tennessee? What are the challenges that are faced in these communities there? And also if there are some initiatives or strategies that have been put in place to help meet demand.
Well, I haven't had the opportunity to visit as many rural hospitals in Tennessee, but in my previous role in Arkansas, I had the opportunity to visit just about every rural hospital. So my team provided on-site education because oftentimes hospitals don't have the funds or staffing to send nurses for continuing education courses. Or for example, obstetrical providers, if there's only one obstetrical provider, they have to arrange coverage for that provider to go to courses. But I do have a huge admiration for rural nurses, rural healthcare providers, because they have to be nimble and they have to have a large amount of general knowledge. For example, depending on how many patients are in the hospital or the census, nurses have to be flexible on where they work. One day they might be in the ICU, the intensive care unit, and the next day they might be in the obstetrical unit. So they have a breadth of knowledge that many years ago when I was a staff nurse, we worried about being pulled to another unit. Whereas they're constantly pulled to other units for coverage. Sometimes rural hospitals use travel nurses or locum tenens providers, especially for emergency departments or obstetrical services, and that's a huge expense for hospitals. Another point is healthcare providers may see health conditions less often, and so they may need additional guidance and support for care. So they might call a tertiary care center for referral or guidance in treating a condition that they don't see very often. And one thing that I think is to be noted, that many nurses and I think healthcare providers experienced a lot of burnout due to the COVID-19 pandemic. So they potentially switched to other professions. And right now we're seeing a trend, I hope it's a short-term trend, of decreased applications to nursing programs. So that's going to impact us long-term. The other thing that we want to make sure is that the healthcare providers in the community reflect the community. So we want the same racial makeup of the providers as with the community, and we have to be mindful in how we recruit people to go into nursing or medicine and other healthcare professions. Many nurses and providers, especially in rural areas, are aging and approaching retirement age. So we need to replenish those providers.
Yeah, so I think that's it's very interesting having this conversation, because there are just some things that just are not intuitive, like just the whole fund of knowledge that a nurse working in a rural community needs to have. It's being, you're not sure which unit you'll be working, when you're coming into the hospital. You may be in the ICU versus on the surgical med-surg floor or some other places, and you have to be extremely flexible in that. And clearly burnout has been a major issue across the board. The number of folks, the numbers are really staggering, that folks who are leaving the medical profession, some attributing a lot of it to COVID, even though there had been some trends in recent years regarding the decrease a number of folks getting into medical specialties or so. But I think this is very it's a trend, and I hope, like you said, that it's a short-term thing and not it's not a long-term trend or so. Let's see. I know we've talked a little bit on some of the issues or so. A lot of the areas that require intervention, or where we see a lot of problems. But let's turn a little bit to some solutions. So, you all have raised many issues for us to have a very vivid picture of the state of healthcare in our rural communities. So, now let's taking a statewide view. What would you say should be the top priority areas to be addressed? And let me start with you, Dr. Kincer.
Sure. Again, it may be who you talk to. Special interest groups may want their agenda pushed, but I'll try to be neutral and look at the big, broad picture. And when we do community assessments, the things that I will talk about rise to the top. So the top priority currently are opioid deaths. For those of you not from the United States that are on the call, some 30 years ago, we had a big push by pharmacy to start prescribing opioids for pain control as the fifth vital sign. And we started getting into people having a lot of use and misuse of opioids, and physicians prescribing a lot of it. And probably 6, 7, 8 years ago, state boards came in and started putting limits on physicians on these prescribing. And we started seeing the number of prescription opioids going down. But sadly, when people have opioid addiction, just because the physicians quit prescribing it doesn't mean that they will quit using opioids. So what did they do? They came up and started synthesizing fentanyl, which fentanyl is an extremely potent opioid, and it has what we call a narrow therapeutic index. In other words, the difference between pain relief, which it's meant for, versus death is a very narrow amount of medication. And so when non-professionals are synthesizing this in the community and people are just using it, you're going to see that what happened is the number of opioid deaths actually increased, which is not what we expected at all when we started doing legislation to decrease opioid use. We now see an increase in opioid death. So at this point, the battle's not a legal battle, but a lethal battle. And we need to focus on the lethality. The addiction, sure, we need to try to decrease addiction, but we first need to get a handle on the lethality of it. And so the short-term reality is probably more focused on things like naloxone training and access, so that people in the homes and the communities where we know that we have people that are misusing fentanyl would have a drug like naloxone there just in case there is an overdose. Now, some people might come back and argue and say, well, that's just propagating the use of the synthetic drugs. Well, I won't get into the politics of that, but if people are dying from the use of synthetic drugs and we've got the antidote and we're not providing it, then we're not really battling the lethality of these drugs. Another priority, as we've mentioned a couple of times, is the high infant mortality rate in Tennessee compared to the rest of the United States. This has gotten a lot of attention in the Tennessee legislation this year, and money has been made available for doula training. Doulas are people that go into the homes and educate the mothers before and after birth and help them with the stressors of pregnancy and birth and so forth. And while this doesn't improve access to physicians directly, it does place knowledgeable individuals with the population that's at risk. And so that's good legislation that's been passed. Mental health is definitely something that needs to be addressed in rural areas. There's high levels of depression, there's high levels of adverse childhood events, high levels of suicide and drug abuse, and all of these need the attention. Sadly, the mental health workforce is very low. Even in urban areas, it's hard to access mental health. But in rural areas, it's pretty much non-existent. And that's a workforce issue, plus it's a payment model issue. And then lastly, we need to start looking at, and we have been looking at, it's just hard to make progress with tobacco abuse, access to food or food deserts, community recreation, education, all of these need to be addressed. Bottom line thinking is limited access to education and employment in rural Tennessee, which drives poverty, and then poverty drives poor health behaviors and lack of access to care drives poor health outcomes. Again, this is not a new issue, but the disparity between rural and urban continues to widen.
Yeah, so I see those priority areas. That's tackling opioid deaths, and you're stating it's a lethal battle that we have to be dealing with. High infant mortality rate, it's a big one. Mental health, that's a real challenging one to deal with. Mental health, just as you said, the workforce is very low, and then dealing with tobacco abuse and misuse. And Dr. Rhoads, do you see similar priority areas, or are there other areas that you want to add?
I agree with Dr. Kincer, all of the points that he made, and increasing services for people living with that. One other thing, or a few other things, we know where providers are educated, they're more likely to go back. So I think to practice there. So I really think we need to have rural healthcare pipelines for people to be trained in rural areas. So it would be ideal for health science centers to partner with rural areas several hours away, so they could bring different types of healthcare providers in to have those experiences, whether it be nurses or resident physicians, nurse practitioners, physicians assistants. And then another thing we could do is expand the use of, which I don't care for the term, but mid-level providers such as nurse practitioners, physicians assistants, certified nurse midwives, so they can help provide care in the rural areas and use telemedicine to connect with the rural residents to specialty providers. So ideally, the rural health clinic could be a one-stop shop potentially for a rural resident. They could go there to see their specialty provider and not have to travel to Memphis or Knoxville or Nashville every single visit. Because if you think of chronic health conditions, many times you have to be seen monthly, every 3 months. And so the transportation barriers are there. In urban areas, residents can choose between different providers or hospitals. In rural areas, to have that specialty care, such as cancer treatment, high-risk maternity care, they have to travel. But when it comes to an emergency, a rural resident has to go to the closest emergency room, so they don't have the option to travel for those. And then echoing what Dr. Kincer said about the social networks and social support and economic development, those things are needed in rural areas. Even a factory, like you said, opening in a rural area, they want a healthy workforce to work in that factory.
Yeah, I think the pipeline is we always when we look at disparities in care, the pipeline, the training pipeline is always a major issue, and training folks who are from the area. It has been shown time and time again that it really helps increase the number of providers who stay in those areas, because they're from there, it's home. So that's a big one. And mid-level providers, they do a whole lot. I think it's similar to what Dr. Kincer mentioned regarding the workforce. That I think the Tennessee legislature is passing something where folks go into the communities and help educate folks to in targeting high infant mortality rate or so. So that strategy is also good. I mean, the issue of telemedicine, I mean, it has all the benefits or so, but I don't know your thoughts on I mean, I know you're a very big proponent, and COVID COVID made that even more so. So can you talk a little bit about, some of the successes that you've seen with telemedicine, Dr. Rhoads?
Well, I will say telemedicine is a tool in the toolbox for healthcare providers. It's not a ready-made thing that will ensure positive outcomes. It needs to be used in proper ways and connect the patient back to the healthcare system and not in pockets or used for one-time use. But I will give an example of a very well-implemented program in Arkansas. They have many rural hospitals, and we are in what you would call the stroke belt. So the incidence of stroke in the southern U.S. is much higher than other parts. And so Arkansas implemented a statewide telestroke program providing 24/7 neurology support from the Health Science Center, as well as in-depth training and mock drills with rural hospitals throughout the state. So it wasn't just drop off a telemedicine cart, bye, we'll see you, we'll move on. So they really trained the nurses and emergency department physicians on how to use it. And then they did mock drills from the patient arrives in the ER. Let's get them to have their scans, and then back to have TPA or the medicine to be administered to combat stroke. And we were 51st in the nation. Arkansas was. You may say, well, how's that? But we were behind even the territories. And in 2011, after implementation of this statewide telestroke program done in a comprehensive manner, they moved up 13 points. So now Arkansas ranks 37th in the nation related to stroke mortality. And so that is an example of a well-done telemedicine program. I will say other telemedicine programs where it's not connected back to their primary care providers or mental health providers, and it doesn't provide a stable medical home for patients. I see issues with that type of telemedicine. I think in one study that I did with older adults in rural areas regarding telemedicine during the COVID-19 pandemic, they wanted to see their healthcare providers by telemedicine. They didn't want to see some person from New York City or California. They wanted to see their provider in Jackson, Tennessee, or Memphis, Tennessee, or Little Rock, Arkansas. And so they wanted to connect back with them.
Well, thank you very much for that. I mean, at the end of the day, as you're saying, telemedicine doesn't mean that folks do not want those connections with their providers. So they still want it. It's not just some random provider that they want to talk to for it. And I would encourage everyone who has questions or so to put your questions in the chat box, and we'll get that in a few minutes or so. In the meantime, Dr. Kincer, let me get your experiences or so. What are some of the initiatives that you've seen, whether it's statewide level, whether it's at the local level or so, that have worked? And importantly, what initiatives or ideas would you recommend to be considered for implementation regarding trying to really improve the access to care for our rural communities?
I think Dr. Rhoads hit on a lot of those, but there's been a lot of money invested in healthcare efforts in our rural and underserved communities with truly little change in outcomes. Economy evolves, and America has evolved from more of a farming community from 100 years ago into an industrial community. And that's caused an exodus, if you will, of people from rural communities into the more urban areas. And it's shifted populations, it's shifted priorities, and most importantly, it's shifted the economic engine that drives United States economy. We're a compassionate country, and we focus on prioritizing and providing healthcare to all of our citizens. But ultimately, communities are going to thrive or they're going to die based on their economic engine. So on this side of the state, when coal mining became obsolete, communities just kind of died out, leaving people without proper education and healthcare. and nothing to take the place of the economic engine of the coal mining community. So those that can leave left, and those that can't leave suffer. And so as the community suffers economically, it spirals downward decade by decade. And so, we came in with some initiatives. Now, the thing about all of these initiatives, if economy is spiraling down, that means that if we're going to come in and provide something, it's going to have to be subsidized by someone or something. And subsidy usually comes in the form of United States government subsidy or the state subsidy, or people end up doing it for free. And free is very difficult unless free is subsidized by charitable networks. Charitable networks can be churches, it can be civic organizations, it can be independent donations, or so forth. So some of the things that work in rural communities are federally qualified health centers, which get a subsidy on Medicare and Medicaid patients. So when they see a Medicare or Medicaid patient, they get paid roughly 3 times the rate at what one would get in an urban area or a non-FQHC. We see rural health clinics that are similar to FQHC, slightly different, but very similar. Again, charitable clinics. Some of the things that's worked in the past are where international medical graduates come in and they're on a visa. And in order to stay in the United States, they've got to go and work in a rural or underserved community for 3 to 5 years to stay in the United States. And a lot of those physicians end up living in the rural communities for a long time. They love it. And that's worked. It's been a great plan and it's worked. Rural loan forgiveness programs. And Tennessee just passed a few weeks ago a loan repayment program for family physicians that are willing to go and commit to a rural community to help pay back their loans, which is family physicians is a much needed driver as a primary care physician. So rural loan forgiveness programs. And then at an education level, Dr. Rhoads mentioned like pathway programs, the old term being pipeline programs, but the newer, more modern term being pathway programs. In fact, here at East Tennessee State University, the Quillen College of Medicine, we have a rural pathway program for college students that want to go back and practice in a rural community. We have 12 students each year, and if they go through the steps during college and make the academic requirements, then they get an automatic acceptance or a guaranteed acceptance into medical school, which is fantastic. This is a new program. We'll see in a few years how it works out. So those kind of things are some programs that have worked in the past.
Yeah, I think wow, that's a lot to unpack there, and but I think the whole aspect of the economic drivers are really big. What happened when coal mining, kind of like went out of fashion? As you said, the communities, many communities just died because just it could not thrive anymore. And it's very interesting regarding the subsidies, whether the state or the government, the federal government will provide, those subsidies, but at least the rural loan forgiveness programs or so are being implemented. So I think there is, that's really nice to see. And I know some folks who have been a part of such programs. I want, if anyone has questions or so, please, submit in the chat box. For it, but I wanted to, ask a little bit. I'll throw this to both of you regarding how you have seen, I know surgical care, in these communities. I mean, they suffer the same kind of like problems that you've mentioned. You all have mentioned regarding nursing, nursing care. Also, a family physician, how to draw people back there, or the critical access hospital to have a surgeon available, in one of these critical access hospitals, just to deal with some of the emergencies or so. And the World Health Organization usually, will classify these hospitals, the district hospitals or so, where you should be able to do a laparotomy or a C-section, or do fixate a fracture or so. Some of these bellwether procedures or so. How have you all seen, surgical care in our rural communities or so? Anybody can take a stab at it.
I'll take a quick stab. Again, I'm a family physician, not a surgeon, but of course, when you have closure of rural hospitals, the surgeon's income is really generated in a hospital setting with surgery. And you close a hospital, there's no economic driver for a surgeon. They're going to leave. And then, as we would say in East Tennessee, just down the road a piece, about 45 minutes down the road is a rural hospital that's a critical access hospital. And they had a surgeon there that would come in and do scopes and minor surgeries and so forth. But they did the financial calculation and the money that they were having to pay to support the surgeon's salary, because the surgeon couldn't support their own salary in a small town. So the hospital had to subsidize that. And then the amount of money that it took to keep the surgery unit open they were not generating enough money to do that, and they didn't have enough money to pull from other aspects of the hospital. So sadly, last summer they closed their surgical wing down, and the surgeon ended up having to move because they couldn't support it. And that's only one example, but I think that you will find that example to play out. So again, I think for rural communities to have a surgeon, it's not going to be a full-time surgeon, and someone's going to have to subsidize them to be there.
Thank you for that. Well, I think we have less than 5 minutes or so. This conversation has really been very insightful. But let me just get some final, remarks, final thoughts from both of you regarding, where we are. I'll start with you, Dr. Rhoads. What are the prospects? It's a lot to unpack. The economic drivers, some of the initiatives being implemented, but we want to be able to attain health equity in our rural communities or so. So what can you leave us with? What words can you leave us with?
Well, I want to leave us on a positive note. I know Dr. Kincer and I both lived in rural areas, and we can talk about the barriers to care or poor health outcomes, but I want to emphasize the positive aspects of living in a rural community. I've lived in rural communities in Arkansas, and I value the connections that you make. You make lifelong friends, lifelong connections with healthcare providers, and they are often a tight-knit community that provides social support for their residents. Most of the healthcare providers are dedicated to the area and really never retire. They give back to their community and are really vested in the area. And I will say I live part-time in rural Arkansas and part-time in Memphis, and that helps me have balance in life. So I have the country life and city life too. So I do want to say there's a lot of positives to rural communities.
No, thank you very much for that. I think you are splitting it 50-50. I wish I could do that for it. No, Dr. Kincer, some parting comments.
Yeah, thank you. I'll echo what Dr. Rhoads said. We sit here and we paint this sort of grim picture, but you have to realize that not everyone, in fact, the majority of people who live in rural communities are doing quite well. But when you look at the number that are suffering, it's still greater than the U.S. counterpart. So I don't want to leave everyone thinking that living in rural America is just terrible. In fact, it is a wonderful lifestyle. But healthcare in rural America has always been a major issue, but it really didn't get the attention that it deserved until about the 1960s, when President Johnson came in and formed the Appalachian Regional Commission to decrease a lot of the economic suffering of our rural communities, especially in Appalachia. And since then, we have seen a drastic improvement in the economy of the rural regions. I grew up in the 1960s and the 1970s when the Appalachian Regional Commission was just getting going. And now, some 60 years later, the healthcare has actually improved to a degree. Education has improved, access to roads has improved. And so we continue to work at it, but the population continues to expand, economies continue to shift, payment models evolve, and we get societal improvements like broadband, internet. But, just one county over from us in Johnson County, 60% of the population does not have broadband internet. So when we talk about using, internet providing healthcare, when 60% of the population still doesn't have internet, it still becomes an issue. So with all of this evolution, we have to try to figure out how we can keep from alienating the rural communities as we evolve. It'll always be an issue. It will always be a battle. But this evolution with a lot of good people, a lot of good discussions like this, hopefully we can keep that disparity from widening further. And maybe through effort, we can close the gap to some degree.
Wow, this has been thank you very much on Dr. Kincer, Dr. Rhoads, and this has been very entertaining, very illuminating, very insightful, and the knowledge shared here to be able to have a good and global view of the challenges, the opportunities, as well as just the great life that is in our rural communities. So I want to thank you all very much for the time. And I mean, I think this is really an amazing panel that, like, at the top of the hour, we are coming in, closing at the top of the hour. I mean, this is like amazing. But thank you very much, Dr. Rhoads. Thank you, Dr. Kincer. Thank you for everyone for joining us. We are going to be continuing this conversation for sure. I want to really wish you all happy rest of the day, and thank you again.